Bismillahirrahmanirrahim. Today we will discuss the management of airways. This is a very important topic because we need this in emergency to deal the airway. Management of airways is indicated when there is marked airway obstruction, giving no time to perform an orderly tracheostomy. Different procedures which can be used to manage the airway are jaw thrust, oropharyngeal airways, nasopharyngeal airways, laryngeal mask airway, usually termed as LMA, then percutaneous transtracheal jet ventilation, endotracheal intubation, which may be orotracheal and nasotracheal intubation, then cricothyrotomy, laryngotomy, or you can say a mini tracheostomy. And the last but not the least is a very important procedure, tracheostomy. This is the most important and invaluable procedure to manage the difficult airway. This is how we perform jaw thrust to maintain the airway. Just grasp the angles of the lower jaw and lift with both hands, one on each side, moving the jaw forward. If the victim's lips are closed, then open the lower lip with your thumb, like this. These two thumbs will help to open the closed lips, while the hands they grasp the angles of the lower jaw to move them forward. Jaw thrust is shown how we perform this procedure. Then comes the oropharyngeal airway. Oropharyngeal airway, they are made up of Portex tube and they are synthetic ones and they are of different sizes, small, medium and large size, according to the age and size of the oropharyngeal airway. When we use this equipment to maintain the airway, we use this in this way. This is the oropharyngeal airway in place. The patient will breathe through it and the air will go directly towards the airway from this distal end of the oropharyngeal airway. This is the nasopharyngeal airway. This equipment is used likewise oropharyngeal airway, but the route of insertion is through the nose, like this. This is the nasopharyngeal airway in place. This is another equipment called laryngeal mask airway, LMA. When it is in place, it will be like this. It is used through the oral cavity, going through the oropharynx, and this cup-shaped end of the laryngeal mask airway is on the epiglottis. So in this way, the difficult airway is managed by this equipment. This is the percutaneous transtracheal jet ventilation catheter. Once it is inserted, this end will be connected to the tubes containing air or oxygen. In this way, percutaneous transtracheal jet ventilation catheter will save the life of the patient in difficult airway. This is the endotracheal tube with cuff. This is the cuff, and this is the balloon at near the distal end of the endotracheal tube. Once balloon is inflated, it will occlude the passage of secretions or bleeding from the upper part of the airway to go down. So in this way, the secretions and blood they are prevented to go down in the lower airway. This is endotracheal tube without cuff and balloon. There is no cuff, there is no balloon near the distal end of the endotracheal tube. This is simple endotracheal tube. If this tube is used, then one has to pack the throat completely to prevent the secretions or blood to prevent going into the lower areas. Once this orotracheal intubation has been performed, then the equipment will be seen in this way. This is the endotracheal tube inserted through the mouth, going down through the oropharynx and then into the trachea. This this end of the tube will deliver the air into the trachea. This is orotracheal intubation. This is the nasotracheal intubation. The tube is inserted through the nose, and once it is in the oropharynx, it will be guided by using this Macintosh laryngoscope, and with the help of this McGill forceps, the distal end of the endotracheal tube is guided towards the larynx. So this is nasotracheal intubation. Now we will discuss the tracheostomy in details. We will discuss this topic under definition, types, indications, technique of tracheostomy, post-operative care, complications, and decannulation of the tracheostomy tube. Tracheostomy is making an opening in the anterior wall of the trachea and then converting it into a stroma on the skin, surface of the neck. There is another term known as tracheotomy. This is just making an opening in the anterior wall of the trachea. So we can say tracheotomy is a step in the tracheostomy procedure. Types of tracheostomy. Tracheostomy may be emergency tracheostomy. It may be elective or tranquil tracheotomy. It may be permanent tracheostomy. It may be percutaneous dilatational tracheostomy, or sometimes it may be mini tracheostomy or precothyroid. So these are the different types of tracheostomy which are usually employed to save the life of the procedure in difficult areas. Indications of tracheostomy. Indications are mainly, number one, to bypass the upper airway obstruction. Second, to remove the retained secretions from the lower respiratory tract. Third, for positive pressure ventilation when connected with ventilators, such as in cases of snake bite or head injury. Number four, to decrease the dead space. And number five, elective tracheostomy. These are the main five indications of tracheostomy. First, we will discuss what are the lesions or diseases or the conditions in which we have to bypass the upper airway obstruction. These are, number one, infections. The infections, for example, acute epiglottitis, acute laryngotracheobronchitis, diphtheria, retropharyngeal abscess, and parapharyngeal abscess. All these infective conditions may need tracheostomy to bypass the upper airway obstruction. Second, trauma. Trauma to the larynx and trachea and maxillofacial trauma. Then tumors, carcinoma of the larynx, carcinoma of oropharynx, carcinoma of hypopharynx, carcinoma of the tongue, carcinoma of the thyroid. Similarly, foreign body in the larynx may in certain situations may need tracheostomy. 5. Edema of the larynx due to steam inhalation, inhalation of irritant fumes or gases, and sometimes radiotherapy as well may lead to edema of the larynx needing tracheostomy. Then 6. Bilateral abductor paralysis. Bilateral recurrent laryngeal nerve paralysis due to thyroid surgery is the most important and commonest cause for bilateral abductor paralysis needing tracheostomy. And the last one is the congenital anomalies in the form of laryngeal web and bilateral choanal atresia may lead at certain situations tracheostomy. Now, the conditions or the lesions in which we need tracheostomy to remove the retained secretions from the lower air respiratory tract. These are number one, inability to cough. It may be due to coma due to any cause, for example, head injury, cardiovascular accidents, etc. Then paralysis of the respiratory muscles, polio, spinal injury, myasthenia gravis, and Guillain-Barré syndrome. Then spasm of the respiratory muscles, for example, in tetanus, strychnine poisoning. Similarly, painful cough due to chest injury as pneumonia. Similarly, aspiration of pharyngeal secretions, for example, in bilateral adductor paralysis, bulbar polio. Then elective tracheostomy is needed in conditions when upper airway is potentially at risk. For example, any other major operation on mouth, pharynx, and larynx, these may also need elective tracheostomy to save the life of the patient, to save the upper airway, to save the airway. Now, technique of tracheostomy. First, position of the patient. The position of the patient is supine position with a pillow under the shoulders so that the neck of the patient becomes extended. So in this position, the trachea will be more prominent. The patient can be, in this way, the surgeon will perform the tracheostomy in a better way. Then anesthesia. Usually, in the tracheostomy can be performed in local anesthesia. Then mopping of the neck from mandible to the upper chest is performed with powdered solution and sprut. Then the sheets are applied on the patient, only exposing the side of the neck where the surgeon is going to perform the tracheostomy. Then incision. Usually the incision which is given is the midline vertical incision because when this incision is given, there is no danger in injuring the vital structures. Anyhow, in the females, the transverse skin crease incision may be performed, which will give a very mild scar in the post-operative period. Then exposure of the trachea, then incision or cutting of the tracheal rings, Once the trachea has been incised, then the tracheostomy tube is inserted, and after inserting the tracheostomy tube, hemostasis is performed by diathermy or by ligation, and then the tracheostomy tube is fixed with the skin of the neck so that the tracheostomy tube may be secured. This is the position of the patient during tracheostomy. A pillow has been placed under the shoulder so that neck of the patient becomes extended. This is the tracheostomy has been performed here, and a gauze has been placed under the tracheostomy tube to cover the wound. This is the vortex tracheostomy tube having cuff and a balloon at near the distal end of the tracheostomy tube. This is the Fuller's bivalve metallic tube. This is the outer tube, and this is the inner tube. This is Jackson's metallic tube having, this is the full tube, and this is the parts of the Jackson's metallic tube. This is the outer tube, this is inner tube, and this is the plunger of the Jackson's metallic tube. Post-operative care. Post-operative care of tracheostomy needs monitoring of the vital signs, constant supervision, suction of the tracheostomy tube regularly, prevention of the crust formation, which may need regular suction, clearance of the inner tube if metallic tracheostomy tube, then instillation of soda bicarbonate or normal saline, and then suction of the tracheostomy tube, and sometimes the attendant may use mucolytic agent orally or locally, for example, mucolyticization. This mucolytic agent will cause softening of the crust, which will be easily expectorated or which may be easily removed by suction tube. Then care of the tracheostomy tube. It will need removal of the crust to maintain the patency. It will need humidification and putting a moist gauze on the tube so that the air going inside should have proper moisture in it. It will help to reduce the crust formations. Complications of tracheostomy. The complications of tracheostomy may be divided into three groups. Immediate complications, which occur during the operation. Intermediate complications, which appear within first few hours or days. And late complications, which appear after weeks or months due to prolonged use of tracheostomy tube. First, the immediate complications. The immediate complications are hemorrhage, apnea due to rapid washing of carbon dioxide, pneumothorax due to injury to the apical pleura, injury to the recrolaryngeal nerve leading to its paralysis, aspiration of blood, injury to the esophagus, and sometimes injury to the cervical spine as well. Intermediate complications, these may be hemorrhage, which may be reactionary or secondary, then displacement of the tracheostomy tube, then blocking of the tube due to crest formation, subcutaneous emphysema, tracheitis and tracheobronchitis due to crusting, atelectasis, lung abscess, local wound infection, granulation tissue formation. The late complications are hemorrhage due to erosion of the major vessel, which may sometimes prove fatal. Laryngeal stenosis due to pericarditis of cricoid cartilage. Then tracheal stenosis due to tracheal ulceration and infection. Tracheoesophageal fistula due to prolonged use of cuff tube or erosion of the trachea by the tip of the tracheostomy tube. Then the patient may have problems of decannulation. This is seen in infants and children especially. Then persistent tracheocutaneous fistula, scar or keloid formation, corrosion of the tracheostomy tube, especially in case of metallic tube, and aspiration of fragments of the metallic tube into the lower respiratory tract. Decannulation. Decannulation means removal of the tracheostomy tube once the primary pathology is over. Now, when decannulation is performed, first give trial by plugging the tracheostomy tube in case of metallic one. If the patient is using synthetic Portex tracheostomy tube, then first make the fenestration in the tube and then give trial. If trial of the plugging tolerated for 24 hours, then the tube is removed safely. Principles of decannulation. The principles are: number one, always decannulate in the operation theater. Second, equipment for re-intubation should be ready, because if decannulation fails, then the tracheostomy should be reinserted once it happens. Number three, after decannulation, wash the patient for several hours for respiratory distress, tachycardia, and color change, especially sinus. If decannulation fails, then search the cause and treat the cause. Now, failure of decannulation. The causes which may lead to failure of decannulation are: number one, persistence of pathology for which the tracheostomy was performed. Second, obstructing granulation tissue formation. Number three, tracheal edema. Number four, subglottic stenosis. Number five, tracheomalacia. And number six, psychological dependence, especially in children. Diagnosis of cause of decannulation. Number one is endoscopic examination of the larynx, trachea, and bronchi. Second, X-rays soft tissue neck lateral view. Number three, CT scan of the neck, axial and coronal views. All these three diagnostic tools will help to find out the cause of decannulation. Treatment is find the cause and then treat the cause which has caused the decannulation difficulty. Thank you very much.